By 2030, we will have more people over the age of 65 than we have youth in this country. We won't have enough providers to deliver care, so access to care will become a huge problem. Data, again, it's not the magic bullet, for those are problems that have to be solved, but it's absolutely the underlying theme. The access to data lets us innovate in many, many different ways to start solving these problems.
One of the most shameful, truthfully, parts of healthcare that I can say, at least firsthand in my opinion, is when I'm seeing a cancer patient that I or one of my team members have to ask the patient, so did anything happen since we've seen you last? Or even worse, during the visit, if I found out that they saw a cardiologist or a surgeon, what did they say? Or, what was the discharge diagnosis? And in today's world with technology and all of the ways we're able to do things, the fact that we are trying to manage patients that, especially when it comes to cancer and the slew of side effects that can potentially come with immune therapy, as well as targeted therapy and chemos, how important it is to know those things. Why are we still at the mercy of frequently calling, receiving a fax, or trying to get a hold of someone just to be able to have the materials to make the best plan? That is what we are talking about today on Target Cancer Podcast. My name is Dr. Sanjay Juneja. I'm a hematologist and medical oncologist, also known as the Onc Doc. And we try to enlighten and bring out things that's going to really help care. And we talk about, again, targeted therapies and diagnostics and AI. But there is this gaping hole that we just never talk about because I guess it's uncool or not exciting, but it's truly very problematic. And fortunately, we have a very special person and interesting, in every bit of the sense of the word from everything I saw online, to be able to share about how we can fix that. Today we have Therasa Bell, the president and CTO and co-founder of the Future of Health Communication, otherwise known as No2. So let's get into it. This has been a passion of yours. And like I said, it's not the coolest topic, but it's one of the most biggest problematic things. It's crazy that I don't know these things are happening. What made you, do you have a personal experience that made that happen? Or is it something you just realize is a huge problem?
Well, it's a great question because I do have a personal experience. It's not why I started the company. I actually worked at a health system. I worked on all sides of kind of healthcare, payer, provider, and went to school for healthcare IT. And it was a long-standing problem. I've been in this for 25 years, even though I'm only 28 years old.
Yeah. I was going to say.
Man, I've been doing it for a long time, and it was just a passion that I saw an opportunity in healthcare. And after spending a lot of time on all sides of the equation, it became very clear to me what was missing in healthcare, and how it was being addressed were very, very expensive. And still today, it's still a common problem, that very expensive solutions that solved one problem and solved it for maybe two providers, right? In a point-to-point connection. And that was certainly not going to be something that was tenable. So a long time ago, when I started the company 13 years ago, looked at it and said, what we really need is to find all the different ways in which healthcare communication is flowing and bring it all under one umbrella. And of course, the ultimate goal was to get to a single healthcare network that was doing that nationwide, but that was a long ways away. And so at that time it was, okay, network of networks is actually, we coined the term at the company, and that ended up being a big deal about 3 years ago. But we started it 12 years ago and said, network of networks, we're going to do kind of one way to get in, like one front door, one API that says no matter what way you come in, we have all the ways covered that you want to share information, and made it really easy, made it a non-decision. But people weren't having to choose, I'm going to communicate this way, or I'm going to communicate that way. And today, and we'll get into it, I'm sure we'll get into it today, but actually the vision of a single healthcare network or series of networks has come true, and that has been in the last year. So that's super exciting, and a long time coming for healthcare. And so it's the first time I can say this, and I've been my own worst enemy as it relates to pessimism, saying I haven't made enough progress. But this year things are changed. It is totally different this year, and I'm super excited for it. So
We pardon this interruption real quick. If you're enjoying this podcast or find it valuable for what we discuss and the education and how people see and think about cancer in general, we would very much appreciate a like, subscribe, and especially a share so we can bring that information as maximally and broadly as possible. Thank you so much for listening. That is so cool. And I want to just immediately ask you, what is it and why? But I'm going to back up for a second because I heard an anecdote, and I don't know if it's true, but I'm from Louisiana. And then, when you think about it, we all had paper charts. I'm not talking about, if anyone's listening and they're like, well, what are you talking about, Sanjay? We have Epic or we have whatever. So of course we see everything. Just so you know, if that's the case, you're very fortunate because a lot of this country, 85% being community America, is not all on one record. I have different hospitals in this city. I have different clinics. They choose different items. Like people drive different cars. It's either Epic or it's Paragon, it's Arco EMR. And they don't necessarily all communicate. So anyone listening, understand that unless you're, in an academic center where every specialist and everything is in the same EMR or electronic medical record system, that's not the reality that a lot of Americans have. So with that said, the anecdote that I heard was when we had a whole bunch of paper charts and even some electronic medical records, it was Katrina in New Orleans that kind of caused a humongous issue. It was like, oh my gosh, we lost, really sad story with Cherry Hospital and everything. But that somehow kind of initiated there needs to be a way to make sure that the data is secure in a cloud of sorts. Meaning, when I say data, by the way, y'all, I don't mean social security numbers necessarily and all this, address stuff. I mean, what were your labs? What were your imaging reports? What was your pathology? How do we secure that? And most of us now, to some capacity, are used to the concept of the cloud, right? It's like, well, you use cloud and gigabytes and I just keep getting charged because mine keeps maxing out. Yeah. I don't know if this is the same thing, but supposedly what I heard was that initiated this whole concept of health information exchanges, otherwise known as HIEs, that in a weird way comes from a federal level that goes, everybody needs to be able to make sure you have people's full path reports. But the problem is the systems of getting onto that quote unquote health information exchange, which, please enlighten me if it's a cloud or how it works. At each state have different varying degrees. And obviously people travel now. So the quality of your HIE also matters. And I hear that's one of the problems in Louisiana. It may have changed by now. Is that, number one, true? And number two, when you say you're super excited and think it's doable, is it because of the health information exchange, or is that just one piece of being able to capture, data and the charts basically of patients and all their care?
So you said a lot right there. I'm going to go back to if you don't mind, I'm going to actually rewind just a little bit before that when you had brought out that not everybody's on Epic. So when you hear anybody talking about healthcare, they're typically referring to a hospital or health system or a physician. That's their definition of healthcare. No offense, because obviously you're a physician. But that is their definition of healthcare. And healthcare is so much wider than that. And as you look at all the disciplines, every segment of healthcare is their own segment. And the information that they collect, what they care about, there's some core stuff that gets shared, but you look at what an oncologist cares about versus a physical therapist cares about versus, all the way over to behavioral health, very different sets of data, right? And sharing of that data, because I get asked the question all the time isn't this as easy as an ATM? If I hear that example again, isn't this like the banking system? We have ATMs. I can go get cash anywhere and I get my banking information anywhere. Well, yeah, you're dealing with 0 to 9. That's literally the data set that you're dealing with here. And when we talk about healthcare is so wide and it's ever expanding, especially as we seek to push care out of the hospital and out of the health systems. Healthcare is so wide, and every segment of healthcare has its own set of terminology, has its own data that they care about. And it makes it really hard to capture health information because health information exchange, just even that phrase, means different things to people. And that's been the problem in this country. So when we talk about like what happened with Katrina, for instance, it was absolutely an accelerator. It started way before that. How we were approaching things, and we've always approached things backwards in the country because we looked at health information exchange as this very complex formula to solve, and thus we would never make progress on it. So we looked at it and said, well, not only do we need to get the information from point A to point B, that's one part of the equation. We also, what data? How do I make sure that this system is sending it to this system a codified way, that it's breaking down into these discrete elements that is machine processable? We were like, we could never get off the starting line. We could just never get off of it. And so then as we moved forward, we saw all these different ways that information was being exchanged. And health information exchange can be a verb, it can be a noun, it can be many different things. And the country, when Katrina hit, you saw a bunch of infusion of capital from the federal government down to the states and Medicaid, where Medicaid was being driven. And every state was given grant dollars to bring up a state health information exchange. What happened, although there's a lot of viable state HIEs, there's a lot of not viable state HIEs, and they just ended up not doing anything of value, but a lot of them did, so be respectful. Fast forward, then we ended up with, at one point, we had 56 HIEs, independent HIEs, and that only solved certain problems because they typically covered a geography. You didn't get how they got participation from providers. They never had a complete record. Just kind of fell short. And so then in 2016, ourselves, Epic, and some other folks formed a network called Care Quality. And I don't know if you're familiar with that, but Care Quality was the first national-based network that actually had vendors participating. So instead of going all the way to the provider, putting in special software at the health system and these different groups, it went up a level. It went to the electronic health record. Now, keep in mind, there's 3,000 electronic health records in the United States. So that's yet another part of the equation that says we've got not only a huge amount of data that we've got to get moving, we also have 3,000 systems that ultimately will want to get connected that have been certified. And how do we start to do that? So that in 2016, it was the first national exchange that came forward, Care Quality and Commonwealth. They're kind of sister-based networks. And one was Cerner-led, one was Epic-led, but you had participation from all these electronic health record vendors and gateways such as ourselves that brought a bunch of people behind us to start being able to query each other for records at a system level. So instead of, again, all the way down to the provider level, it was at a system level. So now when Epic went forward and brought Care Quality forward into Care Everywhere as part of their Epic implementation, they would bring health systems forward, and they almost have 90% participation in that network. We learned a ton from that federal network, governments, trust, privacy, everything that we had to figure out as part of that network. So then you fast forward it a little bit to 2019, and what came forward out of the government was a kind of the starting of what they called TEFCA, and that was the Trusted Exchange Framework Common Agreement. And TEFCA was now the federal government's participation in looking at, hey, Care Quality and Commonwealth really figured it out, how to exchange information at scale. We're going to take all those learnings, and now Health and Human Services for the federal government is going to get involved and start to identify a framework that would not only bring these two networks forward, but also require participation by the federal government. To date, that had never happened. So as we sit here today, it took us 4 years to bring that live. There were 6 of us chosen, now 7 of us chosen to be what they call now a qualified health information network. So we went from 56 states to 2 national, kind of cutting our teeth, learning what we were doing, to now truly a federal health information exchange system that is backed and required for participation by the federal government. So it's kind of a public-private engagement. And now there's 7 of us. If you think about us as the AT&T and the Verizons of the mobile industry, we've been anointed to take care of the framework, basically the power grid for the United States to allow information to exchange at scale. And it's never with that backing, as much as I wouldn't always want federal government involved, because I think it could, limit innovation. It hasn't in this case. And the requirement of the Health and Human Services, the VA, the DOD, CMS, public health, to all get involved and all choose one of these 7 to connect to, that kind of push, and especially with CMS getting involved. And you're already starting to see movement by CMS to do similar to what they did with MIPS and MACRA, to say you're going to participate. And it's going to be a reward system for a period of time, and then it's going to be the penalty if you don't participate at the provider and the EHR level. So that's the reason. I'm sorry that was such a long-winded explanation to say that is why I'm so excited, because it is absolutely getting the participation, the momentum like we've never seen for health information exchange, and it's gonna be the tailwind that creates the change. We have a long ways to go, right, to get there, but we're seeing huge adoption already of TEFCA and QHINs and selection of a QHIN nationwide for this broad participation in the network.
And that participation are those 7 cell phone network analogies, right? You mean like basically everyone having to pick one of those 7, or not having, but I mean choosing one, and those 7, I assume, all communicate the same language and queryable capacity.
We had to go through a whole application. It was a 1.5 year long application process and a testing process with the federal government. Same, what they call the QTF, or a technical framework that we all implemented to be able to talk to each other. And 7 were chosen. There was many applicants. 7 were chosen, and they passed. And we were all kind of anointed last winter as the QHINs. And now electronic health record vendors, HIT vendors, even I would say health systems, payers are all going out and saying, now we're going to find our QHIN. We're going to select our QHIN for connection and start to push information, pull information with each other. And we sit on the governing board for TEFCA as part of what they call the RCE. And we're defining by every type of use case. Could you imagine that privacy is our number one concern? Privacy and security is defining all the different purposes of use in which it could be used. And we're just slowly releasing them. So we started with treatment, actually a narrower version of treatment than what HIPAA defines to get to privacy. And then we start expanding from there. So we go to operations, different forms of operations for payers, coverage, all of those become part of the formula. And we're just taking them one at a time, getting them through the...
Oh, wow. So it's not just labs, radiology reports, clinic notes. So we're talking all of the things that have to do with billing and prior auth. And okay. Wow, that's quite an undertaking. Now I see why you're so excited, because that's amazing.
I sound like I'm on Ritalin.
What's that?
Do I need Ritalin? Is that what it's called?
Right. I mean, exactly. Yeah, you need something newer. But yeah, so that's very helpful. And actually, yeah, very encouraging, because I can tell you with Care Everywhere, one of the frustrations, nobody likes anyone talking about burnout, like from the provider sense, but the click fatigue, if you want to make sure that everything's correct, you go in and click Care Everywhere. I trend things for my patients to show the creatinine graphs and, the kind of up and down. But it's like if something was from something else, it's a scanned document and it's in the under media, and I got to find the media, but it's not actually in the search bar where you can actually show the, the path. So it's extremely broken. And I hope anyone listening that isn't in the records can appreciate that's the annoying part, is the piecemealness. And it sounds like when you have a fluid language of sorts, then that is, conceivable to be able to actually take all of the different points or whatever you're trying to access and be able to look at them with, searches, rather than just here's a document which doesn't even come up in the search because it's under media. That's super, super exciting. I assume, there's so many questions I have. One, I assume the data can't be sold, correct?
Well, that is a great question. So for HIPAA purpose of use of treatment, it is absolutely no, you cannot sell the data. It is there for treatment purposes only, and it's for care coordination, provider to provider communication. Underneath that, there is the opportunity for what they call secondary data use rights. Now that has a lot of scrutiny under it, where folks that pull in and query for information, they have the ability to de-identify it and look at repackaging the data. We don't see a lot of that going on under treatment. And there's a lot of people contesting the use of data that right now. So it's under a lot of discussion to be determined. But as it sits right now, HIPAA does allow for it once the data is acquired, at least in a de-identified state.
Is that in the same sense of, using SEER, the SEER database, anyone listening, like where you can kind of get an idea of cancer metrics and everything that's happened and numbers? And I think in my fellowship, we had to 1 year make a paper basically on any category and use SEER database. Is it similar in that capacity where it is de-identified and you're just trying to make either an appreciation of a pattern or a trend or some kind of, you posit something to believe if it matters or not, and then need the data to be able to justify? Like, can it help progress in one capacity? Because
absolutely.
So that's why I hope people appreciate, like, if we don't like saying things, it has a 30 to 60% chance of working, or 20 to 60% chance of coming back in 5 years. If we don't want to be saying that, we need to know what's happening in the real world. And the only way outside of a trial, which is very narrow, rigid, most, people probably need, for some reason, may have trouble qualifying for a trial for obvious reasons, like if you're on a bunch of meds and this and that. The best way to get real world evidence and make conclusions is to know what is happening. And that's why and where data is such I don't want to call it a hot topic, but important. There's no denying in one capacity It can be used for capitalistic means. Even if it's a therapy that's going to help people, ultimately, it could still be capital or like revenue driven, fine. But I can tell you as a physician that only gets paid for, RVUs, the number of visits you see. Where I get excited is I can have a better idea of the likelihood or unlikelihood or all the stuff that I say, well, we don't know why. Could be because you're on a statin, could be because you're on metformin. I just don't know why, but I need that data. And then I get very excited with the thought of it applying machine learning and artificial or deep machine learning or artificial intelligence, not to make decisions for us, but to recognize patterns we can't even conceive. Right? If somebody is like using Rogaine, and if it decreases the chance of XYZ, those things are conceivable, but nobody's just going to make willy-nilly trials. But then when you have data, at least in a therapeutic sense or treatment sense, you can start into, making these patterns you didn't even conceive to be real. That's number one. Like I said, I had a lot. I'm sorry. Number two, I get super encouraged when you explained all this stuff with the auth and building and all this stuff that maybe we could find some steps in this insanity that is the cost of things and the tax dollars we're paying and how expensive our healthcare system is, that everyone keeps screaming, this is not sustainable, it's going to bust. And then everyone's like, yeah, but we all show up the next day. Like that is terrifying to me when I see like how much the things are cost, how much is covered. Somehow I'm still paying hundreds of dollars for my medications. I don't care, but I'm just like, none of this makes sense. I'm hoping that this can help really a lot of the spillage or leakage for things that are not billed, people that are riddled with medical bills that can kind of pull that data and say, actually, this is what the diagnosis was meant to be, and you're not at the mercy of how somebody billed it. There's just so much there that I think is a mess in the way you described it back in 2016 or whenever this started. You couldn't get off the line. Do you think this can help those things potentially? Like when it comes to like knowing exactly where financially our system is getting so overextended and what the problems may be to fix that?
Absolutely. I mean, for us, that's when we say that it's foundational to solving healthcare's biggest problems. And the healthcare system in our country right now is untenable. We cannot sustain this. That is proven. It is proven factually that we're not going to be able to sustain this. And whether it's our aging population or chronically ill population that's getting sick, 50% of people have either diabetes or pre-diabetic, as an example, right? And then we have provider shortage. And that's truly in every healthcare sector. Provider shortage is a massive issue. We've got to figure out different care models to try to overcome the provider shortage. And just the series of headwinds, and you can slice and dice those headwinds in many different ways. The series of headwinds that we have at the root of every one of them, it is not the magic bullet, but at the root of every one of them is data and access to data, sharing of data, analyzation of data. It is data. So we've got to let the data start moving. And we've always been trying to solve, like I said, we've been trying to solve this whole healthcare equation of data, healthcare interoperability. And it's this stacking effect. So first we got to get the plumbing in place. And that's what we've done. We have the plumbing in place. Now we're getting people on the network, get them sharing information. The next problem is going to mount and say, now we have too much data. Now what do we do? Now, how do we make it? Because our chief health officer, the thing he says to me is not, he goes, Trace, it's not more data coming at me. It's the right data coming at me at the right time for the right information. That's what I want as a provider, because I need to be the most effective. Time is money, and I need to be the most effective for this patient. And because that will be the next set of problems where we take on is now we got the data flowing. I'm going to flood the system. That's not good. So now we got to start putting in layers of, prevent provider burnout, too much information coming at me. Where does it show up in the record? But all of that we have to tackle one at a time. You cannot tackle the entire equation. AI at the same time, this is all converging. To me, it's like magical because it is exactly what's needed. We couldn't put in enough data intelligence without AI sitting in there. We couldn't do it fast enough. It would bring the system to a screeching halt. So now we have the tools with AI sitting on top of it, analyzing it, providing value. Hugely important, but also we're super cautious too as an industry. We're very, very cautious. That's why when TEFCA came forward, a core of us sat at the White House for weeks and said, this is what treatment is. This is who can participate in treatment, to then start stepping into the rest of the purposes of use under HIPAA. So we're making sure we're establishing privacy and we're establishing security because of all the considerations that go into it. It's a lot. It's a big.
It sounds like a lot.
Big undertaking.
Where you do some processing power GPU stuff cognitively, but also potentially, like in a chip. But I'm gonna ask you one thing that I've never asked anybody and maybe I'm even a little ignorant. I know what my definition is, and it's its own podcast. It's probably its own weekend getaway where you have to have things to palliate talking about it. But when you say it is not sustainable or untenable, love that word in this capacity. We'll love it in general. But when you say that, what do you mean? What do we mean when we say that to somebody? It is not sustainable, or it is untenable, and it can't continue. Does that mean like option A, nobody will be able to afford, healthcare, health treatment because insurance companies can't afford it, and so insurance companies go away. So it's just free. It's just the cost of what it is, and therefore we just don't have healthcare. Is it? That's really how I define it, to be honest. Or is it that the country goes very bankrupt because all of a sudden we have to somehow subsidize the cost because there's no margins, and now we're just pouring tax dollars into either institutions, healthcare providers, insurance companies, someone to cover these costs, or just tell industry to lower to where we get very tight on everything else because we have to put all of our eggs into healthcare. How do you define it? Is it both of those scenarios, but the fact just being that either we take everything from everything else we have in this country because of the foundation kind of breaking underneath it, or the first example, how would you define it?
The cost of care, right? So we have no way to sustain the cost of care in the current way we deliver care models, and for the aging population and how sick they're getting. So we're going to run out of cash. Medicare is not going to be able to afford what we have coming at us. And by 2030, we will have more people over the age of 65 than we have youth in this country, with 1.2 more chronic diseases than we've ever had, and the cost of just care delivery in the current way we deliver care. Then we look at the next problem being we won't have enough providers to deliver care, so access to care will become a huge problem. So I won't be able to get into my PCP. I won't be able to get into my specialist. I won't be able to get to the care I need, just simply not there, unless we figure out different care models. So things like virtual care. How do we break the healthcare system of the brick and mortar? How do we break the healthcare system of how we've delivered care traditionally? And there is so many pressures on the healthcare system. It is untenable. It cannot sustain. We're already seeing it break, right? We're already seeing. I went to try to get into a primary care doc 8 weeks before I could even schedule a visit. So those types of things, we've got to break how we've done business and change how we've done business so we can reduce the cost of care delivery, and maximize the providers we have in this country and who are coming through. We have, I can't remember the stat, it was like 25% of primary care docs, family docs are retiring in the next 4 years. We don't have a backfill coming in for that. So what do we do? How are we going to deliver care now? And data, again, it's not the magic bullet for those are problems that have to be solved, but it's absolutely the underlying theme. The access to data lets us innovate in many, many different ways to start solving these problems.
And even see where Village is. Like, my dad's like a Six Sigma. He did Six Sigma Black Belt a long time ago. Like, I mean, still does, but kind of before everyone started doing it. And I didn't understand it. He was like, Sanjay, all these plants or engineering places, there's quote unquote spillage. There's just areas where your margins can be tighter. And so we're like with 6 standard deviations trying to figure out where is the cost going that can accomplish the same with less costs, right? Very simply put, I hope he's fine with my explanation of that. But the point being is that's where at the bare minimum, data can, the interpretation of data can say, are we paying for things that aren't being covered that should be because of a billing code? I mean, it just is endless on the number of things that potentially are just spilling out by dozens of millions, hundreds of millions, who knows, that we can't even appreciate because it doesn't all communicate. Like, I mean, who's going to walk into this facility and check and then the other facility? And if it's not federal, who's going to do it or even has a reason to do it because they're not the ones giving Medicare or Medicaid? Like, it doesn't even make sense when you start thinking about it to assess that unless it's doable, which is what you're trying, one of the things that what you all have done, sounds very laboriously and still laboriously over the past decade or two to be able to accomplish. So, but when I'm glad I asked you this question. So from my understanding, when we say we can't afford it, the first pillar to fall sounds like it will be Medicare, Medicaid, and government provided or federal. But like that's what we mean first. It's like if you have private, corporate, as long as it makes sense for them, I guess, to offer. But the first thing that would go is the majority, which is children, like with Medicaid, and adults Medicare, correct?
Yep.
That's terrifying.
Yeah, they were saying if we don't fix this problem, by 2030, we don't know what we're doing. We literally don't know how to bring ourselves back out of this hole to pay for Medicare, pay for the amount of people coming in that will be demanding from the Medicare resource and the amount they'll be demanding from the Medicare resource. And then you got the provider side trying to just be reimbursed from it. And you look at the healthcare market, the health systems and physicians, they've largely been, Medicare is part of their business, but their mix is primarily private pay and employers, right? So self-insured and private paid employers. And that Medicare, Medicaid population has largely been that senior population in low income. And they're seeking care typically outside of the health system. And we don't have the supporting infrastructure for our senior care environment. And it's all facility based today. So we got to figure out, how do we drive more care to the home? How do we get that care in the home? Because that is the least expensive avenue for care delivery. Well, to do that, you better have access to clinical information in the home. Who's delivering the care to the home? How are they coordinating care? I could go on and on for the opportunity for innovation is incredible.
Maybe that's why GLP-1s are put out recently, so to make sure to accommodate for the cough that are anticipated. Let's just put a lot of GLP-1s and suddenly comorbids and chronic disease will improve. I do think cough will go down a lot because of, I know, pros or cons. Point is, there's just so many things associated with, significant
population, right?
Yeah, overweightness.
Diabetic and pre-diabetic, 50%.
Yeah, diabetic, vascular disease, cancer risk is well documented, arthropathies and knee replacements. So many of the things that have unquestionable data proof that have to do. Unfortunately, I don't think it's this overweightness that's the problem, but it's the adipose fatty tissue to a large degree. There's even data that says where it is matters. Like if you have a thin stomach, it's not the same as if it's centrally trunkly located or metabolic syndrome. And it's pretty compelling evidence, and hopefully that reduces a lot of things. Now, I have one question that I have tried my best to try to address, and I've never quite hit it spot on or on the nose. I'm going to ask you, I've already talked broadly, and you have as well, about what data analysis can do as far as, in my world, expectations with cancer. What are the right treatments? What are the survivals? Because I can look at all of the de-identified and know, oh, this person with your tumor type that has your aggressiveness and how fast it replicates, got this, and I can just interpret all that. Not me, but something or someone, right? So that'll help us kind of narrow down the advice we're giving. Indians have different responses to things than Caucasians, and we don't really count for that or anything. But all that to say, me asking or encouraging someone to share their data is almost always a greater good concept, like the ones I just said. Like, it's for me 10 years from now, it's for my kids, it's for, what is your answer for this thing that I cannot shake or beat down? I'm not saying that privacy isn't important and having your data isn't important. I have a fear that a lot of people think it means social security, address, and identity theft, and less so that people actually care about them knowing their, again, de-identified necessarily what their CBC is or something that may, make their life insurance policy higher. I get all of those very much, but you and I know that's not even what we mean when we say share your data in certain capacities. What is your answer to explain to somebody why somebody would want to, or is it really only the greater good for the most part? For now, that would be a convincing reason.
Meaning, if you were expressing that to a patient?
Yeah, like if I want, a lot of people get nervous when they say, "Would you like to share your data to get this analysis, whatever it may be?" Generally, people click no or don't want to, right? Without getting an explanation, they don't get told why they would, why it's important or what, anything. It's just, would you like to? And it's like, no, I wouldn't, right? Because broadly, it just seems like something you don't want to do.
So it's interesting you bring that up because it's, we haven't seen too much of an issue with it. It's because I don't know if it's because it's wrapped under the traditional consent where, as the patient comes in, they go through the consent process. Can we release your information to other providers? Can we release your information? And that's where it falls under for these networks. It's treatment. Oh. So it's HIPAA purpose of use of treatment. And underneath that, there's a lot of protection for the provider in that. But that's how information is shared today. And we haven't seen, I'm sure there's patients that opt out, but typically they're not. And it's because these networks, for that purpose of use, They're right now only treatment-based networks. So it's provider-to-provider communications that are part of it. When we bring in these other purposes of use, and then it's an opt-in model, and the collection of consent takes on a far different meaning and what they have to assert. So treatment-based is opt-out. It's part of, you cover it today when you send a fax to another provider. And sorry to use that word, but that is real. That's what it's covered under. And these networks are, in essence, the same thing as communicating via fax. And patients don't opt out of that.
Gotcha.
Because it falls underneath that. As soon as you go to, for other reasons, so it gets into, we're going to release your information for clinical research, or we're going to release your information for these other purposes of use as defined by HIPAA. What's required by you and the technology vendor that's doing that for consent capture and then assertion of that is far different. And I think you'll see a significant drop off when patients will actually opt in. It's a different network protocol when they say, yeah, you can use my information for that. What's coming after treatment, interestingly enough, is individual access services. So there's always this argument that it's my data. I'm the patient. That's my data, right? And I should have access to it. And totally agree with that. Not everybody agrees with that. And this country is not built around freedom of information for the patient to easily get it. That's why we've seen some of the legislation come through that's information blocking. You can't, if the patient asks for records, you have to deliver it in a certain time frame. But the next purpose of use that we're covering for the network, and it's literally how are people getting onto the network, is for the individual to be able to request their own records. It was felt that that was the most important thing because then they could be responsible for the distribution of those records to whoever they wanted. But with individual access, the level of identity proofing to say that patient is who they say they are, you've asserted it, you've confirmed it. There is like clear, does that ID.me, if you're a clear member, like you go through the airport, there are participants in that identity assertion. And the individual, now we see all these access services that are coming up, apps on my phone, different things that says, yes, I can access my own records from the national network now. So instead of logging into my chart one time for Epic at just one facility, and I got to do that at each different place that I've been seen, it's now a federated access for that individual to say, but they have to be, their identity has to be asserted, collected, and the way that we serialize that request, everything that's put around that request becomes very specific to that patient. But if we solve that problem, the individual access, they can then choose who to distribute instead of trying to solve it for life insurance and solve it. Let the patient get access to their own records and then distribute back to whoever's requesting it. So make sure the providers are taken care of. That's our first step. Make sure patients can access their own records, and then they can be responsible for the distribution. So you're going to see Apple participating in this. You're going to see a lot of consumer-based applications participating in access to clinical information. And that's where I get really excited, because that's where we'll really see the magic for the individual. Now, what they do with the information, that's a whole different equation. Like there's some vendors, and I won't use their names here, that they won't give the whole, what they call the designated record set that sits inside, for instance, Epic. They're not giving that whole thing to the patient. They're not doing it. And so they're subsidizing certain parts of that information out, or pulling certain parts of that information out and saying, this is what the patient can actually consume and understand, so they can pull that information back into my phone or do whatever I need to do with it. So that long-winded answer to, I don't even remember the question.
I love it. Well, you're saying like,
I don't remember the question.
So these third-party apps that are coming out and basically you could opt in. They're not third-party apps, but they're companies that have a mission. When the patient gets on, puts their name and somehow identifies himself in whatever capacity is required and sufficient, that app, that website, that company is pulling from what you call the federal exchange, correct? That's like the official term.
Federated network. They're just pulling from all these
federated network, all
these different systems. Like if you have 90% of Epic Health systems on it today, and I've seen an Epic Health system here, and I've been at this Athena doctor and this, using different electronic health records, I just put in I assert my identity, and it goes out to the distributed network, pulls back all their records, and then they can choose to distribute those.
Now, what's the format of these records? Is it is it AI or not AI? Is it structured? So, in my head, somebody's like, what are you talking about, Sanjay? I think of PDFs or just like texts and whatever. Then there's AI learning and structuring, where it's not just a series of ink on a paper that it has no clue about. It's actually interpreted and learned it which I'm sure there's a lot of third-party apps for that. And then now it's actually retrievable when you say, show me my radiology report, it'll show you and put in different terms. The third way, which people are going to be like, really? I thought that's over. But blockchain is one way I think of things too, is where you can actually have it. Apparently there's these things called Satoshis within Bitcoin, which are megabyte-based, capacities to store, say a voicemail from a loved one that's passed or something to just really secure it beyond the cloud. What is the format? I assume it's not .jpeg.
It could be. So that is therein lies. So we talk about, there's 3,000 EHRs. There's healthcare is a very wide definition when we talk about healthcare, and there's different business. Every segment of healthcare is a different type of business, what they care about. Actually, it started in 1995, but roughly around 2000, I was part of a core group that came out with a schema. It's called CDA. It's Clinical Document Architecture. That follows, it's a very structured format, and we picked just a bunch of common document types, discharge summaries, operative reports, things like that, lab results, things like that were constantly shared in healthcare, at least mainstream healthcare. We're still expanding out into other parts that were constantly shared, and we took the core elements of those and we structured them into common documents that were machine processable but eye readable. And because what was important to maintain was that data elements for data, like if I had you read a discharge summary, right? Or you read an operative note or a SOAP note, whatever it is, the narrative is really important. Being able to read through it is very important, but you also want to pull out certain key data elements. So maintaining the story of the patient was really important, and it's really hard to do that with structured data, right? But we did it. And so the CDA format is actually XML. Unfortunately, now XML. Whoa. At the time, that was state of the art. That was state of the art at the time. And those are being exchanged at scale. So last year we did about 20 billion CDA documents across our network alone. In healthcare, we're doing about a billion a month, and it's growing 20% month over month, just being in terms of information being exchanged. So what now goes across the fax machine today as a discharge summary is in a structured data format through CDA. So that's your number one format. But 80% of the transactions through these networks are structured XML. We're moving to FHIR. I'm sure you've heard all about that. We're moving to FHIR, but FHIR, what's interesting about FHIR, it's not the magic that people think it is for provider to provider care delivery, because it's discrete data, right? So again, you're going back to med allergy, like individual, and sometimes that's super valuable. That's all you need. But other times I need the story, and FHIR itself as individual discrete data doesn't solve that problem. And so we really need a combination of both. And so, yes, it's largely structured, totally mineable, and constantly improving. There are some PDFs. There's JPEG still being shared. There's DICOM images being shared that are there, but it's mostly structured. I'd say it's largely structured. And by 2026, the requirement to be on the network is that it has to be all structured to be able to share that information. Is that... Wow. I really nerded out right there. Sorry.
No, I love it, but it's also a little overwhelming just thinking about. I mean, in my head, I'm just like, that's where LLM, language learning models, make a lot of sense, because now, if it just stayed in that form, the CDA that you mentioned, then you could still have these, or even FHIR, like even those little metrics. I assume an AI model could learn the language and be able to put it in prose or whatever you asked it to, assuming it's
intentful
accurate.
Or purposeful LLMs will be where it's at, right? So we see these large LLMs out there today that are kind of, I won't call them blood instruments, they're amazing, but that's what they are, right? So as we get more discrete and we get very focused to specific outcomes, LLMs built around that, and it's amazing.
Game
right?
over.
It's game over. It is literally game over. And that's what needs to happen next, is get to really in like a purposeful LLM for an outcome.
Because at least for a physician, so you said two ways that, a healthcare system is unsustainable. One is cost, but two is the fewer providers. Part of that is, surely my opinion, the amount of time it takes for me to just have the variables and details I need to make the plan is debilitating, right? For me to go through, it doesn't take a doctor brain to read. I just need to read it. I just need to find where it is, what month, what year, what note, where they had the first like tumor lesion or whatever, that it takes forever. It just takes that's not doctoring. That's just getting the details. And then when you have complicated histories or long-term, things that you're figuring out, or when was the medication change, because you're trying to figure out if it's causing the renal failure, that this medication caused renal failure, but to go back and see when the renal failure started or when it was normal, and then find when that was started at which doctor's office, you can imagine something so simple that took the doctor brain, which is, I know this causes it, but to actually figure out when it was started and if the renal disease was present prior to or after is very simple. Like that process, except it's not, because all you're trying to do is figure that one fact out. I need anyone listening to understand an LLM that, to your point, that's very focused, that like is say just a lab interpreter or whatever, for me to say, when did the GFR, the filtration rate of the kidney, start dropping, and please plot every antihypertensive med or metformin or whatever, and give me the dates. My life, to just do the bare minimum of the right thing for the patient, has gotten so much easier and simpler.
What's your typical time today? Like, and I'm sure that's a pretty broad question. Like, for what's standard for a new oncology patient that comes to you? I don't know what I'm asking, so that probably sounds right.
So I mean, very simply, a new patient, you're right, telling cancer, survival, all this stuff is an hour, but every single patient after a new patient, because oncology is such a deficit in general, is 15-minute visit. It's 15 minutes if they're toxic from chemo and you need to address those toxicities and still have to give the treatment or decide not to. It's 15 minutes because you can't predict when you're 1,000 patients, unfortunately one progresses or has a recurrence. It's still that same 15-minute visit. You can't just knock it to 45 minutes. So everything is 15 minutes at every 15-minute mark with no margin. So it's 8:15 was one, then 8:30, 8:45, 9 o'clock, 9:15, and it's all the way around till the afternoon, minus, if you're lucky, 45 minutes or an hour at lunch, if everything was done in 15 minutes. If no one was late, if no one had a family member that was really interested, you didn't know they were coming, so you're going to explain everything because they flew in, any margin of error has bled into that 45 minutes or an hour of lunch, and then the afternoon is the same. And then you round on patients or whatever. It's like the consults that you didn't anticipate. So very simply, my question is, when do you think that's happening? Which is actually your question. When do you think it's like it's at nighttime? It's at nighttime or super early in the morning, because in the daytime you're seeing patients. If there was tons of oncologists, you wouldn't be seeing patients every 15 minutes. So it's literally impossible. But I mean, it's possible, but it's impossible during business hours. But how much quicker would things be if my staff wasn't asking my team is amazing. So my medical assistant says, what happened? What got started? Oh, you were admitted? Oh, like, what was the diagnosis? What they trade? What's your medrex? All human, right? Does it need to be human? Is that a good use of staff that we know are deficient to actually have to ask things that are just objective? Is it a good use for then our nurse practitioner to go in and then I'll also ask, when did you start this? We are getting details for then the doctor to come in with the updated detail just to start the actual doctoring and healthcare process. And it's unbelievable how much time goes in a community setting to get the things you need to start the job. And that's where I think the world changes with this kind of thing.
Well, I started this company for the provider. Like, it's the passion. Everybody always say it's for the patient, and it is, right? At the end of the day, but the provider has to be taking care of others' patients. We can't do anything about that. I hear that experience, and like, my dad has Parkinson's. A year ago, he broke his hip, and went through, obviously he went through hip surgery, hip replacement, and then went into rehab through the whole process. At the end of the rehab visit, I came back to Minnesota, which is where I'm at right now, and I took him to his 3-month appointment with his neurologist. It was a standard checkup. It was a week later after he had gotten out of rehab. And I wheel him in, and I get in there, and they hand me like a 10, it's just generic intake form, right? You have to fill it out. I'm looking at him like, there's not a chance my dad can fill this out himself, not a chance. And it's very like, you've never met him before. And this is a standing every 3 months. And they clearly, even though it's part of the same health system, they clearly had no idea that he had just been through. And it's this, I mean, she's going to be starting over, right? Starting over with, where is he at? What's his new normal look like? And so I walked up to the front desk and I said, clearly, you don't know that my dad had a major event here, and she's going to have to start from the beginning. I'm happy to fill this out, but it kind of feels like a waste of time. And So we go in to see the doctor, and I show her in her record, because she just didn't know, where she could pull my dad's record and see everything. And I thought about, like, from her perspective, her coming in, she's having to reset everything. So she's going through a whole new set of questions with him, trying to figure out, it's not a checkup, a 3-month checkup, how much that puts her on her heels. It destroys her day. Who knows? It backs up every other one after it. At the same time, the patient experience, they're like, don't you know me?
Yeah.
Especially, I was thinking that from an oncologist perspective, that's such an intimate relationship, I would imagine. Like, don't you know me?
I see them every 2 or 3 weeks. It shatters me when they're like, you didn't know, like, you didn't talk on, like,
kind of bother you.
That's the concept of moral injury. The moral injury is like, you feel guilt because they're justified, but there's no conceivable way that you would know. Like, when I walk out, it's like, by the end of the day, 40 messages, doctor, I need it.
I don't know how you do
Doctor calling about whatever. What am I going to do? When am I going to call? And a lot of times it is my patient I return most, but they're receiving the call after working hours, and I'm calling it during working hours because we already went through. I have a visit every 15 minutes throughout the business day. So what, like, and you have 1,000 patients out there, they're going to have issues. So you are calling, and those are the good ones, right? Which I believe all of us mean well. We're doing that to let someone know because there's no other good way to know, right? And that's insane. That's insane in the tech world that we live in, that's the way that it just has to be done. And that's out of goodness of your heart. But you're still going to drop balls all the time. And I think patients are always justified to be disappointed. But on the flip side, and I appreciate you having both angles, you're saying, like, how would you? Like, especially here, it's not in my system. Like, I can log onto 4, like you said, and copy the date of birth and go to all 4 before the visit because I got out, say, 2 minutes early. And I can go to all 4 record systems every time they're coming back and paste, find their name, open, and figure it out on each one. But that takes forever, or my staff can't. But that's less staff. I mean, it's crazy.
I don't know. I literally don't know how you do it. I don't know how providers stay with it and not completely have a nervous breakdown. And not to make this about you, I'm turning the table.
They're true.
I don't know how they do it. It's literally, I will tell you, coming out of experiencing my dad's transition to the rehab facility, and then rehabbed in the neurologist and getting in-home care, 0 sharing of information. And at that point, I just thought, I failed. I'm like, this lifelong endeavor.
Like, it's my entire life. Yeah, and here we are.
I give up. Yep. I left that plane ride. I was super depressed the whole plane ride on. Like, I haven't made a dent. Then I'm like, nope, stick to it. We're right at the cusp, here of pushing forward. And I hear these stories like what you're telling me, and it overwhelms me for you. I like feel so much anxiety, but it also gives me that energy. Like, I've got to solve this problem. Yeah.
I just love, I can tell your empathy, sympathy, like, you get it. And that's why you're making your mission. That's why I was so excited to bring you to this podcast, because I just know people hear the word data and they tune out, but they don't understand that everything I just explained gets better with proper data use, like putting it together, acquiring all of the disappointments. I don't understand necessarily that when you're disappointed, you're justified. Having data, shared the analytics, and being able to, like, and then one day LLMs where you'll have to opt in. This is how we get doctors, and any kind of provider or healthcare professional. We want to spend more time. Trust me, every day's moral injury is guilt. I wish that 15 was 25 minutes. I wish that person I met, I could have given him a more lengthy explanation, even though I've seen him for, 6 months. The first time I met this person's mom or whatever. Every time you wish you could have. These are the kind of things that allow more face-to-face time, more attention, deeper explanations, because of the unbelievable extent of data retrieving that's like monopolize your staff, number one. And number two, how things don't get missed. If you're worried that there is what's called polypharmacy, or that, like, that unexplained fatigue, or why did this happen? No, a patient shouldn't be responsible to think, well, I got started on this at this person's, and they did a swap on this medication in my rheumatology clinic. Why would they know or even think that could have changed the metabolism of another drug? Like, but it happens all the time. It makes me sick to think how many toxicities and problems that aren't immediately obvious, but are just symptomatic and debility, is probably because of mix of meds. The MARs aren't even equal, like, across the country necessarily by any stretch, unless they're pulling and resetting. So the point is, I hope anyone listening isn't like, I hope they realize, and I want to believe that people are in this field and people are doing what you're doing because they want the best, right? You and I have isolated how the system is problematic and it wears out the people that are in the system, patients, providers, and that it can be done better. And that's what's so exciting is this is a way for, let's call us naive. We believe both are equally impassioned and want to see this process get better, are aware of its shortfalls. But I don't think everyone's aware of why it's that way. And I hope this podcast and conversation makes people realize that. And what you, with decades of time, have facilitated to potentially nail on the nose the things that I have been saying that are challenging. That's why I saw you get excited just now. And I'm sorry to hear that about your father, the experience. But I got stoked when I saw you stoked because you're like, this is where what you described is why we've been doing what we're doing. And it's about to be a home run. And that's unbelievable. And I really appreciate that.
Well, I appreciate you recognizing that. If you would have interviewed me like 5 years ago, still, it was a lot of progress being made. I would have been like, yeah, we probably got a decade ahead of us, maybe 2 decades. And we still do. But the progress, it is a marked difference. And the next 2 years will be pivotal in healthcare. And just seeing electronic health records and health systems becoming much more connected and much more consumed. Those that don't, they'll go away. They can't persist. But it's exciting. It is truly a different time in healthcare.
Is there anything healthcare professionals or patients, just because it's both on this podcast, can do to help? Like, everyone says, well, participate in policy and all this stuff. I think that's intimidating for a lot of people. I do a lot, as much as I can. But is there anything like an organization, like what can say healthcare providers like, yes, I need this in my life sooner than later because I'm burning up from everything Sanjay described? Or if patients are like, I want to be able to make it easier, to have all the stuff about me presented to my, physicians. I want them around. Is there anything we can do?
Absolutely. It's funny because our chief health officer, you guys speak a lot alike in terms of the things, just how you package and what's important to the physicians and what your daily life is like. His statement is, in the provider community, there's a lot of learned helplessness, right? So we've accepted kind of what's been given to us. We just kind of take what's there, but the ability for the provider community to push in to their electronic health record vendors or push into their any kind of health information technology and say, are you connected? Why don't I have that? And push into these vendors and start educating yourself. It's certainly don't want you to be experts on interoperability. We wouldn't expect that, but to expect it of your EHR vendor and force it on them. Absolutely. That is the best thing we can do to just keep the momentum moving forward. And then start just pushing the industry. Look for your trading partners in your provider community. Ask them to get connected because most of the time they have the technology. They just don't know it. And it's going to take kind of that groundswell. I do think a lot of it will come from the federal government, but yeah, absolutely. Let's not learn helplessness. So
I heard Blue Cross here in Louisiana was trying to do something along that effect. I don't know if it's pushing to one of those 7, and they haven't done it yet. But my ear stood up when you said they don't even know they have it, and I guess that's what you mean when you say push it into or opt in. You mean into those 7, like the federal little. Yeah,
that's coming. They even probably have something different today, like Epic has Care Everywhere. My neurologist or my dad's neurologist, she uses that in health.
I see.
She had no idea that she even had that functionality in her software. It's just learn it. So don't accept it. Ask, get yourself informed, get your staff informed. And that kind of groundswell will create the movement from them.
Everyone to kind of get on board. I thought it was mandated in October of last year or something for everyone to be on the exchange in some capacity.
It depends on the state. If that might be at a state level, that's not required at a national level. But information blocking came in as a mandate. You couldn't block information from patients getting access to it, providers requesting records, which was good. Unfortunately. That's what happened last October.
Okay, gotcha. Well, thank you so much. This was amazing, and I am just very eagerly on the sideline rooting you on.
Well, thank you for giving me the opportunity. I'm now your biggest fan.
There we go.